warm tone, but it's also very toxic. So it was discontinued in the 19th century and replaced by titanium white as a pigment, which is used even up to this day. Well, white is what we use in a chromatoprectomy technique, and we use a medication called triamcinolone. So if you've ever had an inflamed joint or an inflamed disc, very likely you've gotten a Kenalog shot or triamcinolone shot into that inflamed area. I'm going to warn you, if anybody's squeamish, there's a short little section of video that's, I think it's kind of cool. Some people find it a little bit icky. So if you want to avert your eyes, now would be the time. This is an actual vitrectomy case. And so what we do is we make an incision into the eye. And then in that little tube, the cannula, we run a saline solution. So that saline solution is constantly infusing into the eye. And we make 2 other incisions. Okay, that's kind of it for the gruesome stuff. All right, so this is inside the eye, and now what we're doing is taking out this very white. This is an old hemorrhage. This is really easy to see. This diabetic patient had a hemorrhage in the eye for a long time, so long that it turned white, and that's really easy to see. You don't need to stain anything. The vitrectomy comes out great. There's, the retina, laser mark. Everything looks good. But here's a case of what's called vitreomacular traction. So here's that OCT, and remember, there's supposed to be a little dip in there, and the vitreous is taking the daylight out of the retina. So here's what a normal vitrectomy looks like. So when it doesn't have all that white gunk in it, the normal human vitreous is very transparent. I mean, that's how you see through it. But it's very difficult sometimes to see during surgery. And sometimes it's really difficult to peel off of the retina. So we put a little triamcinolone, white stuff, that helps us see these structures a little better. We're yanking, okay, we're ready, right? There, the whole sheath of vitreous comes up, and now, because we can see it more clearly, we can remove it better. So that the rest of the procedure goes way more smoothly, because now that you can see stuff, you can deal with it more effectively. Another view of that is some triamcinolone. It stains the vitreous, it sort of sits down on the vitreous, and so we're yanking, trying to get the vitreous up. Finally, I have to use this little lighted pick, and let's do a yanking, and finally, boom, it comes up, and then that whole sheet is now stained with triamcinolone, and again, making it way, way easier to see. Well, blue as a pigment has been made out of all kinds of stuff. Azurite, Egyptian blue, copper-based pigments, cobalt blue, and finally we get to a more modern pigment, ultramarine. So blue, which would figure so prominently in Gainsborough's Blue Boy, or during this whole period of Picasso's life, the so-called blue period. We use a medication called trypan blue, which is actually used really more in the laboratory to stain non-living tissues and non-living cells. And in a condition called epiretinal membrane, this is a little scar tissue that appears on the retina. So again, kind of remembering the normal OCT, that little line right there, that's scar tissue on the retina, and all this junk there, that's scar tissue builds up on the retina. So we're trying to remove all that stuff that is extremely thin and difficult to see. So during the vitrectomy procedure, first of all, I'm going to inject air into the eye. So air is now being pumped into the eye. And then you just dribble a little bit of this trypan blue onto the retina. It stains that epiretinal membrane. And then you use a little suction device to get out that stuff. So here we're just aspirating all that blue dye out of the eye. And then we can see see this little membrane. So here's a surgical pick, and I'm just trying to scrape this very delicately off the retina. But now that you can see it more easily, it becomes way easier to remove all of it. So this is just a little cannula that has little synthetic sapphires on it, a little diameter sapphire tip cannula. All that membrane comes up, and then you take a really big forceps and just kind of pull the whole thing out. And finally, green. Green has been made in pigments from emerald green or copper-based, again, toxic sorts of compounds. Malachite was used in ancient Egypt. Viridian is sort of a modern pigment that's used in paintings, and so green that would figure so prominently into Victor Oliva's painting The Absinthe Drinker, and Edouard Manet also painted an absinthe drinker, and absinthe was this stuff that was very popular in France in the late 1800s and early 1900s, and a little bit of that green stuff could have a profound effect. And so similarly, we use a compound called indocyanine green, where just a little bit of it is very helpful. And so during a procedure for what's called macular hold, at the end just showing you the OCT slides, remember there was a dip, whoops, there's a big hole there. So patients who have a macular hole have a situation like Degas, where they're legally blind, usually around 2200, because of that hole that we saw just as the scan passed by. So we inject a little bit of ICG into the eye. Let it sit there for just a little bit. Then again, a suction cannula is used to remove the excess dye. And then, once we see what we're trying to peel, this is a structure called the internal limiting membrane. It's actually a normal part of the retina. But because we want to peel that, because it leads to successful closure of the macular hole, we're peeling this little membrane. And just to give you an idea of the perspective here, that hole is usually around 300 to 400 microns in diameter, so 1,000 microns in a millimeter, that's less than a half a millimeter in size. But this membrane comes up very easily because we can see it well enough to peel it. And now that that membrane is all been peeled off, it's kind of a cool view. You can see the iris, through the pupil, optic nerve. You can just take a forceps and just remove that membrane entirely. There's the macular hole. This is kind of one last little promo technique. This is what laser looks like in the eye. So this has got a filter on it to protect everyone in the operating room, so it kind of ends up being yellow. But the laser, when we apply it to, for instance, this diabetic patient, kind of looks a little bit like you're painting with light. Well, in summary, we've sort of covered refractive disorders and how they probably don't really explain the major works of art, the major movements in art. We talked about Claude Monet as having cataracts and how that affected his works, and that Edgar Degas probably had some sort of inherited retinal condition. We talked a little bit about Mary Cassatt, who had cataracts and also very likely diabetic retinopathy, and color deficiency that forced Charles Merriam to work in black and white etchings and engravings. We talked about how medication toxicity probably was really not an issue with Vincent van Gogh, about vitreous hemorrhage and how it affected the work of Edvard Munch, and macular degeneration, how it affected Georgia O'Keeffe. So really, whether your name is Jackson Pollock or Mark Chagall or anybody, we really do recommend that everybody start being screened. If they're diabetic, they have to get screened every single year. Many of the people in this room are not yet 40, but at the age of 40 is really when a routine screening ought to begin, looking for signs of glaucoma, cataract, any sign in the retina that there might be diabetes or hypertension. So I want to finish with a couple of shameless plugs. Again, no financial interest in anything. I've given you shameless plug number one about this really great book, and this is Dr. Marmor and I. He's trying to be a cowboy. It was actually Go Texan Day when he came to town. Shameless plug number two, I work and practice with 9 of the smartest people I've ever met. And so it's sort of wanted to give a shout out to my partners at my practice. Another shameless plug, and this one's really important. Go see art in a museum. These days, with all of the stuff that's online, you can see an awful lot of stuff online, but there really is no substitute for seeing things, whether it's at the Blather or Museum of Fine Arts. There's really no substitute for actually experiencing art firsthand. A great example of this is you really have to go to Florence to see the David at the Galleria dell'Accademia. But when you're there, make sure that you go into the room that's right next to it, because you will find no better example of what Michelangelo talked about. His job as a sculptor, he thought that the sculpture was already there. His job was simply to release that sculpture, and you'll find no better example of that than the four incomplete statues that are referred to as the prisoners, and that's in the gallery just off to the side of the David. You can't experience that in any other way other than looking and walking around and marveling at that work. And similarly, there's no image on the internet that could do justice to Sunday on the Island of La Grande Jatte at the Art Institute of Chicago, where you can see how the technique of pointillism developed with Seurat painting these little itty-bitty dots, and you can experience close up what that looked like, and then back away how the color all blends together. Another shameless plug for CPAM stuff that we're working on and is likely in the pipeline. Music as a healing force in medicine, whether Parkinson's disease or special needs children, effect on recovery, of stroke recovery, even in ICUs and recovery rooms from major procedures, and visual arts and healing. And CPAM is going to start installations of artworks throughout the Texas Medical Center. So there's a lot of stuff where art and music and healing and medicine are all going to start blending more and more. And then finally, shameless plug, I practice at the same hospital that I was actually born in, at the Methodist Hospital. And in this wonderful, beautiful, trained